Hi everyone, my name is Nicole Owen and I'm a third year medical student at Warwick University. I've been asked to do a confusion case with you today, and here is our case. We have a 67-year-old female who presents to her GP with her daughter, who is particularly worried about her mother's increase in confusion. Now, the first thing we want to ask is, how long has the confusion been going on for? Is it acute and has been happening over the last few days or hours, or is it chronic and has been going on for weeks or months? This helps us to differentiate between delirium, which is acute and fluctuating, and dementia, which is chronic and progressive. There are lots of different things that we can ask about in a history of someone with confusion. Here are just some of them. We can talk about the patient's behaviour and how this has changed. We can ask about their baseline and what they're usually able to do independently. We can ask about when they last opened their bowels, as constipation is a common cause of confusion. We can ask about their bladder function, and actually urinary incontinence paired with something like a gait disturbance might point us towards something like normal pressure hydrocephalus. We can also ask about whether or not they're having any urinary symptoms such as stinging or burning on urination, and any suprapubic pain, as this may point towards a urinary tract infection. We can ask about systemic symptoms such as fevers or rigors, which might point towards another infective cause, maybe a lower respiratory tract infection, maybe a UTI. We can ask whether or not the patient's been experiencing any pain, as pain can cause confusion. We can ask about their current mobility and how this has been affected since the confusion started, and whether or not they're considered to be off their legs. And we can ask whether or not this is a unilateral weakness, which might suggest something like a stroke, or whether or not there's a sensory deficit, which might suggest something like syphilis or vitamin B12 deficiency. We can also ask whether or not the patient's had any recent falls, and actually in any of those falls, at any point have they had any trauma, any head injuries, as this may point towards something like an intracranial pathology, such as an intracranial hemorrhage. We can ask about the patient's oral intake. Are they dehydrated, as this may cause electrolyte imbalances, which can cause confusion. We can ask about their current medications. Are they taking anything like an anticholinergic or an antipsychotic that may cause confusion? And also ask about their alcohol intake, as we all know that chronic alcohol intake can also lead to things like Wernicke's encephalopathy and Korsakoff psychosis, which can both present with confusion. It's important as well to ask about the other aspects of your history, so to ask about the rest of the social aspects such as occupation and smoking, and also important to ask about their past medical history and obviously their ideas, concerns and expectations. Now, with someone who presents with confusion, it might be quite difficult to actually ask them all of these questions and get a logical response. So what's really important is we take a collateral history. And a collateral history is a history from someone that knows the patient and what they're usually like. In this case, we've got the daughter who's present, and it would be really great to ask her a lot of these questions. Another thing that's really important to cover in the history is to ask about the impact on activities of daily living. So this is where we ask about their baseline and what they're usually able to do, and actually how has the confusion impacted on that? Are they still able to do their general housework, their cooking, their cleaning, and are they generally safe around the house? One of the things that we can use as clinicians to assess their cognition is a cognitive assessment. So there's lots of different cognitive assessment tools out there. We have the 6CIT, we have the GP-COG, and the 4AMT as well. So all of these can be used to assess the patient's cognition. We can then do other examinations. So we can do a respiratory examination where we might be looking for things like crackles, suggesting a lower respiratory tract infection or a pneumonia. We can look for things like neurological signs, so we can look for the lower limb weaknesses or decreased sensation that might suggest something like a stroke if it's a weakness, or if it's a sensory change, then we might be thinking something like syphilis or a vitamin B12 deficiency. We can do a cardiovascular examination because some arrhythmias can actually cause confusion. We can do an abdominal examination where we might see suprapubic tenderness and actually abdominal distension if it's urinary retention. We also should do the patient's observations, so look at their temperature. If they got a higher temperature, which might suggest an underlying infection. Obviously, remember sepsis and your sepsis 6. We can also think about things like their O2 sats as well if we're suspecting a respiratory cause. So it's really important that we look at the other investigations that we can do. So things like urinalysis might be indicated if we're suspecting a UTI, looking for our nitrites. We can do a sputum sample if the patient's got a productive cough. We can do a full blood count, so looking at for signs of anemia or white cell count being raised. We can do our inflammatory markers, so our CRP, our ESR. These might point towards an infective cause. We can do our U's and E's. So again, this is looking for things like your dehydration and your kidney function. We can do our calcium, we can do our LFTs looking at hepatic encephalopathy, we can do our thyroid function tests, our vitamin B12 and folate, HbA1c, and also things like a chest x-ray might be indicated if we're suspecting a respiratory cause. Our ECG, looking for those arrhythmias we've already spoken about. Our CT head, and this is obviously very important if we're suspecting something like a stroke. We can also do our STI testing, so HIV and syphilis testing. And things like our drug level testing as well. So things like digoxin, if the patient has an overdose of digoxin, this could actually present as confusion. So in this patient, we had a 67-year-old lady who came in with confusion. So on examination, we actually found that she has had a cough for quite a long time and she's a chronic smoker. However, in the past week, it's been more productive than usual. She's got a bit of dyspnea, she's pyrexial, she's got some crackles in her right base of her lung. She's also a bit hypoxic. She's got a raised white cell count and a raised CRP. And actually, when we do a chest x-ray, we can see a consolidation in the right base. So in this case, we'll be thinking about something like a community-acquired pneumonia. Here are the common organisms that cause community-acquired pneumonias. However, there are also some atypical causes as well that you should be aware of. One of the things that I want to talk about is the CRB-65 score. So this is a score that indicates the risk of mortality in this patient. So C is confusion, R is your respiratory rate, greater than 30, B is to do with your blood pressure. So it's a diastolic blood pressure of less than 60 or a systolic blood pressure of less than 90. And 65 is the age of the patient. So from what I've told you already about this patient, we can already say that she's going to score at least 2 because she's confused and she's over the age of 65. Let me tell you a little bit more about the scoring. So a score of 0, with clinical judgment, you could probably manage the patient in primary care. A score of 1 to 2, with clinical judgment, you should decide whether or not to admit the patient to hospital, but definitely consider admitting the patient for management. A score of 3 or 4 means that we should probably urgently admit this patient to hospital for management. So how are we going to manage this patient? One of the things I've already told you is that this patient is a smoker, a long-term smoker. So it's really important that we offer smoking cessation. We should also give her a course of antibiotics. So the NICE guidelines indicate the first-line antibiotics in this patient would be amoxicillin. However, if the patient was penicillin allergic, we might use something like doxycycline instead. We've obviously done a sputum sample that I told you about earlier, and actually when that comes back with sensitivities, we might want to change these antibiotics accordingly. We should consider a chest x-ray after 6 weeks in this patient because they're over the age of 50 and they're a smoker, which puts them at increased risk of malignancy. One of the other things, once the patient has recovered from their acutely unwell phase, we should consider something like an influenza vaccination. I hope that was helpful. Thank you.